Welcome back to Science of Medicine. Today I want to give you a brief physiologic overview of pulmonology and cardiology. So the pulmonary system is a very critical component of your body. It is housed primarily within your thoracic cavity in your chest, and it's comprised of your lungs, which occupy most of the space within your thoracic cavity, as well as tubing to get air to and from those lungs. So the intake side on this comes both through your nostril as well as through your mouth. There's a common area in the back where they meet, and goes down the front tube in your neck, which is called the trachea. Now the trachea will go down further into your chest and bifurcate into the right side and the left side of your lungs. And then those bronchial tubes will further split until they go all the way out into small sacs at the very end, which are called alveoli. And the alveoli are the site where gas exchange is going to occur. You will need to exchange oxygen and carbon dioxide, picking up oxygen in your blood and dumping carbon dioxide into your lungs. Now, when you're breathing in through your nose or through your mouth, it will go down the front tube instead of the back tube, which is going to your stomach. That's your esophagus. And there's a little flap that comes down from the base of your tongue called the epiglottis, so that when you're eating, you don't get things that shouldn't go down the front, like food and liquids, down into your lungs. You also have a set of vocal cords which open and close and can close to try to prevent other things that have made it past the epiglottis from making it down into your lungs. Now, in your lungs, there is the right side and the left side. The right is comprised of an upper, middle, and lower lobe, and the left comprised of an upper and lower. There is a small, what's called a lingula lobe in the left side, but there is no middle lobe because your heart will actually sit in this cleft on the left side. Now, it's important also that you recognize that in order to have that gas exchange, you have to move new air into and old air out of the lungs, and that is facilitated by these lungs being placed in the thoracic cavity. The thoracic cavity is at a slightly negative pressure, and the absolute amount of that negative pressure can be modulated by the muscles, predominantly the diaphragm at the base of the lungs. And when this diaphragm goes down and is flat, there will be an increase in intrathoracic pressure, an increase in the negative portion of that thoracic pressure, and air can then come in. And when it bows up and relaxes, then there'll be less pressure and air can go out. So, two separate things that I want you to keep clear about the pulmonary system. The first is that everything that is important that's going on in the lungs is occurring as a gas exchange. Respiration is the reason you have lungs. So respiration is gas exchange. It is occurring predominantly at the alveoli, those little sacs. And I need to have oxygen be exchanged, which are necessary for all of my aerobic processes. And that oxygen is carried by hemoglobin. My hemoglobin will carry 4 molecular oxygens in my blood. Carbon dioxide, a waste product from that Krebs cycle, which will generate carbon dioxide in water, is transported in the erythrocytes of the red blood cells mostly as bicarbonate, and it is what is determining the pH of my blood effectively. In order to have that respiration, I have to have the movement of air into and out of my lungs. The movement of air into and out of my lungs is called ventilation, and it is under the control of the nervous system, which is predominantly in the brainstem and the medulla oblongata and the pons. Now, the diaphragm is skeletal muscle. It does obey our conscious effort. I can make myself breathe more quickly or less quickly, but it also is under an automatic system, an autonomic nervous system, which is governed in that respiratory system. In order to decide whether to ventilate more rapidly or less rapidly, I have sensors for both the oxygen and the carbon dioxide. My set points for each of those are about 40 millimeters of mercury for carbon dioxide and about 95 millimeters of mercury for my oxygen. So, as I mentioned to you before, ventilation is the movement of air into and out of my lungs. It's occurring primarily as a result of movement of my diaphragm in the thoracic cavity, which is under a slightly negative pressure. When I inhale, my diaphragm will flatten. That will pull the lungs down and increase interthoracic negative pressure, and that allows air to rush in through my nose and mouth. When I exhale, my diaphragm will relax and it will go up at an angle, and when it does that, the intrathoracic pressure will become less negative and air will spontaneously flow out. I do have some additional muscle movement between my ribs. Those are called intercostal muscles, and also muscles that are up in my neck that connect to the top part of my rib cage, such as my sternocleidomastoid. Most of the time, these contribute a very small portion to the amount of movement and ventilation. But if there is a person that has respiratory distress, they can provide an essential portion of that ventilation. Now, when I'm actually ventilating, I'm ventilating by moving air into and out of my lungs. Under normal conditions, when I'm at rest, that is moving air into and out of like this. And that breathing in and out in a relaxed state is given by what we call a tidal volume. Now, I have the ability to breathe more deeply or exhale more. For example, I can take a very deep breath and access what's called an inspiratory reserve volume, or conversely, I can breathe out and access an expiratory reserve volume. And so my total amount that I can ventilate in my lungs is given by the sum of those three volumes. And if I wanted to do something like that, I would have to inhale completely and exhale completely. That's called my vital capacity. Now, my total lung capacity is actually the sum of that vital capacity and a small residual volume, which is keeping my alveoli from collapsing completely on each other. And that residual volume is something that I can't normally access by breathing. So the ventilation of my alveoli is what I care about, because that's what's allowing for the gas exchange. And I can change this by changing the frequency of my breathing, or I can change it by increasing the total volume that I'm taking up. In this case, I would have tidal volume. I could increase it to inspiratory or expiratory reserve volume. But regardless of what volume I have here, I have a certain amount of dead space. That is, place that is not alveolar for that gas exchange, my trachea, my bronchial tubes, and so forth. Normally in a human adult, that's about 150 milliliters compared to a tidal volume, which is normally about 500 milliliters. Now, as I mentioned, this ventilation is under the control of the central nervous system. I have within the respiratory center in my brainstem and my medulla oblongata and pons the ability to increase or decrease my respiratory rate. And that is done in response to stimuli from sensors for both carbon dioxide as well as oxygen. Carbon dioxide, I would normally want to have around 40 millimeters of mercury as my set point. If it goes higher than that, it means that I'm building up carbon dioxide in my lungs, and I'm going to stimulate my diaphragm to contract more rapidly. That is, I'm going to increase my respiratory rate and blow off that carbon dioxide. Similarly, I have carbon dioxide, I have oxygen sensors. In this case, they're in blood vessels like the carotid arteries going up my neck and my aorta coming out of my heart. And they are actually responding to changes in oxygen. Low oxygen level stimulates an increase in respiratory rate. Now, if I'm breathing at a normal rate, and the reason that I'm not oxygenating has nothing to do with breathing too slowly, breathing more rapidly won't change my level of oxygenation. But if I were passed out, if I were hypoventilating, then this low oxygen level will actually be beneficial to me, because this increase in respiratory rate will increase ventilation and hopefully increase oxygenation as a result of that hypoventilation. But what happens if I have conflicting stimuli? If I have an oxygen level that says breathe more rapidly and a carbon dioxide level that says no, you're breathing fine, or a carbon dioxide level that says breathe more rapidly and an oxygen level says no, you're breathing fine, which one wins out? It turns out that oxygen wins out always. So if a person has a stimulation related to oxygen, that is what is governing, and carbon dioxide is secondary. This is really important because you may have a person that is hospitalized with a worsening of, let's say, their emphysema or chronic obstructive pulmonary disease. These patients will have an increase in carbon dioxide as a result of their disease process, and so they will be stimulated to breathe more rapidly. As a result of that, unless they were hypoxemic, you would not put molecular oxygen on them because it would decrease their respiratory rate. It would inhibit this increased respiratory rate, and they would end up building up additional carbon dioxide, which they're needing to ventilate. Now, the sensors for the chemosensors for carbon dioxide are located in the brain. The chemosensors that are sensing the oxygen are in these blood vessels. They go up to the respiratory center. That respiratory center sends the signal down to the diaphragm through what's called the phrenic nerve. The phrenic nerve comes off of the spinal canal, the spinal cord at about a level of cervical 4 to 5. And so that's why if you have a neck injury, especially at this or above this level, you can actually then not be able to breathe, not be able to ventilate. If I look at the respiration, this is occurring at the level of the alveoli. This is a highly vascular area and with very large surface area, as you can see by this light micrograph. So the ability to exchange gases is very facile in these alveoli. Very, very thin-walled alveoli can allow for oxygen to be taken up into the blood and carbon dioxide to be given off. At sea level, if you're in Memphis, Tennessee, that's 760 millimeters of mercury if we're at 1 atmosphere pressure. I've got 78% nitrogen, 21% oxygen, about 1% argon, a little bit of carbon dioxide, but essentially very, very low, assuming it's a dry day, and this is excluding water from this. So the partial pressure of oxygen then at that sea level is 160 millimeters of mercury, and if I look at the oxygen reaching my alveoli, it's about 105 millimeters of mercury. Some is lost along the way it's being used. So on the lung side, I've got a higher concentration of oxygen than I have on the capillary side, so it should be spontaneous for the oxygen to go from the lung into the hemoglobin. Similarly, carbon dioxide in the red blood cells is at a higher concentration, about 46, after these metabolic waste product is being carried away. And in the lung, it's about 40 millimeters of mercury in the alveoli. So it's spontaneous to offload that carbon dioxide. Now, can I pick up the oxygen in my hemoglobin? Yes, I can. This is what's called the oxygen saturation curve. On the y-axis, I've plotted the saturation of oxygen onto the hemoglobin. It will take 4 molecular oxygens on the hemoglobin. So you can think about 0, 25, 50, 75, and 100% corresponding to those 0 to 4 oxygens being taken on. And as you can see, out at about 100 millimeters of mercury of oxygen, I've saturated this curve. That is, I filled up my hemoglobin with 4, and that's shown out here. Likewise, as I go down this curve and offload it, I'm giving that oxygen up to my tissues, such as muscle, for example. I can modulate this a little bit. That's what this red curve is here, based on my temperature, based on this small molecule called 2,3-DPG, or based on pH, to be able to offload it a little bit. But that's not the primary focus of what I'm talking about today. Once I get to the tissue, here's an oxygen saturation curve for myoglobin. Oxygen saturation for myoglobin compared to hemoglobin here in green shows that I can very clearly accept at the very 100% or very high oxygen or very low oxygen levels, it is a spontaneous process to give up the oxygen to the myoglobin. That is, another way of saying that is that there'll be a greater saturation of the myoglobin for any given same level of partial pressure of oxygen compared to hemoglobin. So it's more stable to be on the myoglobin. On the carbon dioxide side, carbon dioxide in water under the influence of carbonic anhydrase will form carbonic acid, which will dissociate into bicarbonate. This is actually what's transported in the erythrocytes, but it's very easy for me to go between carbonate or bicarbonate to carbon dioxide as long as I have this carbonic anhydrase. Notice that this does affect pH, which is why I had mentioned about this. Now, sometimes a person will have respiratory failure. They'll either have respiratory failure from having too low oxygenation, that's called hypoxemic respiratory failure, and they also can have hypercapnic, in other words, too high a level of carbon dioxide respiratory failure. When that happens, I might have to put them on a mechanical ventilator where I control the volume and the rate at which they're ventilating, and I can do this to control their PCO2 level. I can give them a certain fraction of inspired oxygen that allows for me to control their oxygenation. There is another thing called positive end expiratory pressure, called PEEP, that basically is involved in keeping the alveoli open and therefore exchanging gas, that also does control oxygenation. So let's give some examples. Let's say a patient has diabetic ketoacidosis from their diabetes mellitus where they've missed some doses of insulin. In this condition, they'll increase the acidity of their blood, that is, their pH will decrease. How would this affect ventilation? So remember, I mentioned to you that if the pH is changing, it's changing the PCO2. So if I have a decrease in pH, it means that I'm increasing carbon dioxide, and that increased carbon dioxide leads to an increase in the ventilation. And this was first noted by Kussmaul, who is named after. So people with this condition, this diabetic ketoacidosis, will many times be found breathing rapidly and deeply. What about if you're a native Memphian that's at sea level and you go out hike in the Rocky Mountains above 10,000 feet? If you look at the alveolar pressure of oxygen at 10,000 feet, it's about 73 millimeters of mercury instead of 104 at sea level. So how will this change your ventilation? How will it change your oxygenation? So the low oxygen level should spur an increase in your ventilation, but you're breathing low oxygen at the higher elevations. And so you're not going to change your level of oxygen by adjusting your ventilatory rate, assuming you're not hypoventilating. So instead, you have to adapt. And there are different mechanisms that we have for adapting to that higher elevation. Or you have to carry your own oxygen, which you shouldn't have to do at 10,000 feet. All right, how about your heart? Cardiovascular system. So the heart lies on the left side in most patients, or most people. And it is a pump. It's actually two pumps side by side. The two pumps, the left side pumps out to the body, and the right side pumps back to the heart. And the reason for that is by the time the blood comes back to the heart, it doesn't have enough pressure to go through the oxygenation process in the lungs. And that's why I need a pressure pump to go out to the lungs. But the right side of the heart is, under most circumstances, a very low pressure side. The left side is pumping out to the rest of my body. And that left side is important because if I don't maintain enough blood pressure, then I can't perfuse my tissues and they'll die. Now, the antechambers into which the blood comes are called atria. The one on the left is called the left atrium. The one on the right is called the right atrium. And the muscular base portions of the pump are called the ventricles. And they're really what are squeezing out the blood to either my body or to my lungs. Now, arteries are the blood vessels that transport blood from the heart. May or may not be whether they're oxygenated. Do not learn it that way. Arteries transport blood from the heart. Veins transport blood back to the heart. And the capillaries are the connections between these two. So I have my pump system, and I have to get some names. I have pump coming back from my body into the right atrium and then going into the right ventricle. Now there's a valve between those two, that's called the tricuspid valve, and there's a valve before it gets pumped from the right ventricle out to the pulmonary artery going to the lungs, and that's aptly named the pulmonic valve. It'll come back in through the pulmonic vein into the left atrium and go into the left ventricle through the mitral valve, and then it will get pumped out through the aorta, through the aortic valve, to the rest of my body. And as I mentioned to you before, that the purpose of that heart is to actually transport or pump blood out. I'm going to transport the blood, which is going to have nutrients, heat, cells, going to take waste back and dispose of it through various places like the lungs and the kidney and the liver. And in order to do this, again, it's really critical that I have pressure, because I can't push that blood along unless I have pressure. So if I look at this circulatory system, on the high pressure side, which is my systemic circulation, those pressures are pretty high, and it's pulsatile. It increases during systole, where I'm squeezing the blood out of my ventricles, in this case my left ventricle, to the body, and then it drops off as I fill up blood into the ventricles. That's called diastole. Now it doesn't drop down to zero once I do that, because I have some recoil from those blood vessels that are known as the arteries. And as I go through this process, I will actually lose pressure as I go through the body. Partly that's because I'm bifurcating, I'm actually splitting off blood vessels, and partly because as I transport that blood further and further, I'm losing some of that pressure in resistance. If I look at the pulmonic side, or the blood that is being pumped to my lungs, that's a very low pressure side, very, very low pressure side, because the only thing I need to pump that blood through is the lungs to be able to oxygenate it. Now, I can measure like a mean arterial pressure, which is basically 2/3 diastolic pressure plus 1/3 systolic, because I spend about 2/3 of my time in diastole as opposed to systole. But the pressure on the systemic circulation is much higher than it is on the pulmonic side. All right, so many times when people are learning about the cardiac cycle or the cardiovascular system pumping, we think about this in our mind as being broken into two parts. It's not broken into two parts, that just helps facilitate our understanding of this. I have a side that is electrical, and I have a side that is pumping. The electrical activity is driving that pump, but we want to think about it in two different ways. So I'm going to go through the electrical activity, and then I'm going to go through the pumping activity. So if I look at the electrical activity, I have cells that are located in the right atrium, which are in the SA node, sinoatrial node. And these pacemaker cells are beating at a given rate. They're normally beating at about 60 to 100 times per minute. I can modulate how fast they're doing this. I can make it so that they beat faster under the sympathetic nervous system, or I can make them beat slower under the parasympathetic control. Now, once those pacemaker cells fire, they will cause depolarization of the muscle in the atria, both on the right side, and there's a little offshoot that goes to the left side. And they'll go all the way through the atria, causing depolarization and contraction until they get to this portion which is called the AV node. And then there's a brief pause. The reason for this is so that you get one signal that's going forward from that time, because there'll be slightly different time frames for it to go, for the electrical signal to go from the SA node down to the AV node. If it takes a short path directly, it'll arrive there first, as opposed to one that will take a little bit longer path. So the AV node, there's a brief electrical pause, and then it will travel down the bundle of His, which is in the interventricular septum, the muscular wall between the left and the right ventricles. Now, once it goes down there, it will then propagate outward from the base of the ventricles upward to allow for depolarization of the cardiac muscle to squeeze the blood from the bottom of the ventricles out the top, either out the pulmonic artery or the aorta. Now, it turns out that there are backups in this electrical system. The backup first is just below the AV node in the bundle of His, and there are a set of pacemaker cells that if nothing comes through the AV node, if for some reason there's some blockage, you don't die. You have these pacemaker cells that will beat at a slower rate, normally around 40 beats per minute, but 40 to 60 is what we traditionally teach. And so if no signal comes down the AV node into the bundle of His faster than that, then these backup pacemakers will actually fire. And likewise, in the Purkinje fibers at the base of the ventricles, there are backup pacemakers that are about 20 times per minute. So if you don't get anything down the bundle of His faster than that, then you'll actually be able to fire those. Now, these backup pacemaker cells in the Purkinje fibers are not good enough. You can't put out enough blood if you're beating your heart 20 times a minute to maintain, normal activity or anything like that. You're normally going to be horizontal, but at least you're going to be alive. And in this electrical activity that you might find on an EKG, you see that there is a change in potential across the leads, and then a decrease, increase, decrease, and another. And this corresponds to that electrical activity that I just talked about as you're going through the heart. In fact, actually right here, these what are called P waves, these are the atria that are depolarizing. The depolarization of the ventricles along with the repolarization of the atria are occurring here in what's called a QRS wave, and then this wave out here, which is called a T wave, are the repolarization of the ventricles. And so you can actually measure this electrical activity that we just talked about. So let's use a problem as an example. Let's say a patient is placed on 3 new medications, digoxin, metoprolol, and diltiazem. All of these work via different mechanisms by blocking the conduction of the electrical signal to the AV node. If they do this, if they're successful, what will be the heart rate of the patient, and why is this the case? Well, remember, if I completely block a signal to the AV node, the SA node pacemakers don't determine the heart rate. In fact, the backup pacemakers in the bundle of His are determining the heart rate, and I'm actually going to see a rate somewhere around 40 to 60 beats per minute. All right, let's talk about the pump activity. So in the pump activity of the heart, I have the pump activity where I'm squeezing blood out of the ventricles. That's called systole, either going to the body through the aorta or going to the lungs through the pulmonary arteries. And diastole, where the atria are contracting just to expel that blood into the ventricles. So let's think about this process. So let's say I'm trying to fill my heart chambers. So that's occurring during diastole. All right. Now, the first part of diastole, I'm just going to open my valves that are going between my ventricles and atria, that is the mitral and the tricuspid valves, and allow blood to passively flow in. I don't want to have it flow out, so I'm going to close the aortic and pulmonic valves because I don't want it to leak out. As it fills up, and then I start to contract the atria, I get to fill up a little bit more blood into the ventricles. It kind of gives me an extra 15% or so. And then once I have filled up those ventricles, the left and the right, now I'm going to close my mitral and tricuspid valves and open the aortic and pulmonic valves to allow for me to squeeze that blood out of the ventricles either to my body through the aortic or to my lungs through the pulmonic valves. And that's systole. So if I look at this same diagram of the cardiac cycle, I could look at the volume here in my ventricles, and you can see that I fill it up, and then as I contract, I squeeze out the blood. If I looked at the pressures in my ventricle, I start squeezing, and then as soon as my valve opens, then I start to drain out blood and my pressure goes down. So systole is when I'm squeezing my ventricles to push that blood out of my ventricles to either the lungs through the pulmonic artery or through the aorta to the rest of my body. And diastole is when I'm filling my ventricles and atria. Now, the function of my heart is to pump blood, and I need to maintain a certain arterial pressure in order to do that. I have a measure called the cardiac output, which tells me how much blood I'm pumping per minute. And for an adult, that's generally about 5 to 6 liters, unless you're exercising or there's some problem. So cardiac output has to be something that varies based upon your activity. If I start going and running around the block, I need to increase that cardiac output to keep up with my demand. So how do I do that? Well, my cardiac output is dependent upon my heart rate and my stroke volume. My stroke volume is how much blood I'm pumping out of my left ventricle. My heart rate, I've already said, is controlled by that SA node pacemaker cell with the ability to modulate that through my sympathetic and parasympathetic nervous systems. In the case of increasing my heart rate, like I would want to do if I wanted to increase my cardiac output, it means that I'm going to do it through the sympathetic nervous system, increasing my heart rate. Now, the system is for the most part closed. There is a slight leak through the lymphatic system, and I'll mention that. I'll talk about that later on. But cardiac output is also related to two other things, much like you have sort of an Ohm's law kind of thing. My cardiac output is related to my arterial pressure, as well as inversely related to my total peripheral resistance of those blood vessels. And this will come in handy when we talk about some of the effects of cardiac output. So remember, cardiac output, heart rate, and stroke volume. I can influence my heart rate through my sympathetic and my parasympathetic nerves. For adults, my sympathetic nervous system can increase my heart rate up to about 210 minus my age. So if you're 50, then it would be 210 minus 50, so you can get up to about 160 beats per minute. If you're young, like 20, then it might be about 190 beats per minute. But if you are not using the sympathetic nervous system to increase your heart rate, then you're just dependent upon whatever your intrinsic heart rate is for your SA node. I can slow my heart down, but normally I don't need to actually do this. If I'm exercising, this would be counterproductive. And I can slow that heart rate down only as much as where my backup pacemakers in the bundle of His actually come in. Now my stroke volume can change from beat to beat. And this is an important concept put forth by what's called the Frank-Starling mechanism. Sometimes from moment to moment, I need to expand out my atria and my ventricles. I need to fill up more because I may have a little bit more fluid that's coming back or a little bit less. And so whenever I have too much fluid that comes back, I want to be able to squeeze a little bit more tightly to expel that extra blood. And that process is described by what's called the Frank-Starling mechanism. And it says that up to a point, as you stretch out those ventricles, there will be a higher contractility, higher pushing out of blood as it stretches out those ventricles. Now this is up to a point. You can imagine that with greater overlap of actin and myosin, that I can have more force in pushing the blood out. But if I stretch those ventricles out too much so that I don't overlap the actin and myosin filaments, then the myosin heads can't walk along the actin filaments, and then I actually get a decrease in contractility. And that's what happens when you have a flabby heart, or what's called a cardiomyopathy, an enlarged heart. But normally, I will be able to, from stroke to stroke, change that stroke volume to accommodate my needs. Athletes, for example, are well tuned in terms of their pump because they basically can optimize that stroke volume so that they don't need as much of a heart rate in order to get a certain cardiac output. Now, as I mentioned to you, the critical thing is that I want to perfuse my tissues. That's what my body's heart is doing. It's a pump through which I can actually push out blood and maintain a certain pressure so that I can actually get that exchange of nutrients and all through my blood or heat or whatever is being carried by it that I need. But remember that I said that my cardiac output is related directly to my arterial pressure. So what can happen is I can get some problems developed from this. So let's say I have high blood pressure. So if I have high blood pressure, it's providing a back pressure, a back force that opposes the pumping of blood out my, let's say, left side. If it's the left side, my aorta. And that leads to blood not being able to be pushed out of the left ventricle. Well, that leads to blood not being able to be pushed into the left ventricle. It backs up into the left atrium, backs up into the pulmonary vasculature, and fluid can actually leak out into my lungs. And then we call that pulmonary edema. And then it backs up on the right side, backs up to the right ventricle, and then to the right atria, and then also backs up all the way down into my vena cava and to the rest of my body, which can, back to the capillaries, lead to edema in my tissues. And this is normally present in a gravity-dependent fashion, which means that if I stand or my feet are below the level of my heart, my edema will be greatest at the lowest point, my bottom of my feet, my legs. If I'm laying on my back, it means that my bottom side is actually what's getting edema. I also have a relationship inversely with total peripheral resistance and cardiac output. So my blood vessels, particularly my arteries, are under hormonal as well as nervous system control, and they can contract. If they contract, that increases the resistance by decreasing the vessel diameter. This is a very powerful law. Poiseuille's law shows that changes with the fourth power of the radius, so very, very small changes in blood vessel radius lead to very big changes in terms of this resistance. So it can also influence this. Now, I mentioned to you before about the connection between the arterial side and the venous side being the capillaries. And I want you to understand that these capillaries are somewhat leaky. They're designed that way. It's designed so that a very small portion of our fluid that's in our blood is going to come back to the heart by way of the lymphatic system. And it's going to do that as a way of trying to protect my body so that I can basically sample that lymphatic fluid and look for pathogens that might be present in my blood. But there are sort of two things that dictate the flux of blood out of or into those capillaries. The first is the difference in hydrostatic pressure between the inside of the capillary and the interstitium, which is the tissue that surrounds the capillary. And the other is the oncotic pressure, that is the pressure associated with water being drawn to particles on the capillary vis-a-vis the interstitium. And there are some fudge factors, these little correction factors in terms of filtration. So if I look at this on the arterial side, on the small artery side, the hydrostatic pressure is higher inside the blood vessel than inside the interstitium, so water should get squeezed into the interstitium. As that happens, the hydrostatic pressure drops as I go along the capillary due to water loss, and the oncotic pressure increases inside the capillary because I'm preferentially losing water and I'm not losing proteins like albumin. On the venous side, the oncotic pressure in the capillary is greater than in the interstitium, and that's going to tend to draw water back into the capillary. That small mismatch will lead some fluid that remains in the interstitium, and that's going to be returned, as I said, to the heart via the lymphatic system. When we talk about the immune system, I'll mention this again. So let's talk about an application. Let's say you have a 45-year-old healthy person. You start him on a blood pressure medicine called metoprolol. And this works by slowing the heart rate and limiting the maximum rate at which it can beat. So he goes out and tries to run a 5K race, and he notes that he's just really, really tired. He just can't really run this race. Why did this happen? Well, you should recognize that you did this to him. By giving him the metoprolol, you're limiting how much the heart rate can actually increase. And cardiac output is determined by heart rate and stroke volume. So since you limited his heart rate, it slowed it down, his cardiac output when he was running couldn't keep up with this demand, so he had to decrease his activity level. Suppose you have an older patient that has failure of her mitral valve. So the mitral valve is between the left atrium and the left ventricle. And this leads to regurgitation. So when the blood is being squeezed out of the left ventricle, it goes through the aorta, but it also unfortunately squeezes back into the left atrium. What kinds of symptoms might she have? And figure out why that might occur. So blood is flowing both forward and backwards. So her cardiac output is going to decrease. There's less blood flowing out of the aortic valve because some of it's flowing back. And therefore, she should feel tired. She's not able to exert herself because of this. And in addition, that retrograde flow will cause to a higher pressure in the left atrium and then back up the pump. And that can lead to the things like pulmonary edema and a gravity-dependent edema. So this concludes what we're going to talk about for cardiac and pulmonology physiology, and I hope this has given you a little bit of a basis so that we can actually go forward and solve other problems later on.